So what are they? Well, I read a paper about this, and I'll be honest with you, a lot of the kind of physics conjecture in it kind of got lost in my brain. They talk about impedance and the sort of variability between impedances depending on whether your lung is fluid filled or not, and how the wave is going to be propagated through one area or another. But let me try and distill it to what I understand. Essentially, in your lungs, there are these things called interlobular septae, which in typical circumstances are filled with air, which means that, like everything else, when an ultrasound beam hits the air, it scatters, it gets reflected back quite vigorously. And so you're going to end up with these things like the ring down artifacts. And I've got some animations next that kind of show you why that would be. Whereas in the setting of pulmonary edema or other sort of interstitial lung diseases, those lobula are fluid fill, which is going to cause a impedance difference between a normal lung and a lung that's fluid filled, and cause the beam to actually kind of ping pong, as Mark likes to say, around that fluid, and then get reflected back at a very high frequency back to the probe, causing that kind of comet tail B-line artifact. So just to sort of hammer that home a little bit more, this is actually what we're seeing in the setting of like A-lines, right? You've got your wave that gets sent to the pleura, and the red line represents where it hits air and it can't go any further. It gets back to the probe, but that wave isn't completely diminished even when it comes back to the probe, right? It kind of goes back and forth in a sort of bigger ping-ponging, like if you can think about ping pong players playing across a table. And so what you get is this steady, like sort of reflective appearance below the pleura that represents a lot of the tissues above it, that is sort of diminishing in its kind of amplitude as the probe goes deeper and deeper and deeper, but sort of never really disappears. And so that's your kind of classic A-lines that you're bringing out. As opposed to a B-line, which is usually representing one of these fluid-filled structures where a sort of ultrasound wave is going into it, bouncing around a bunch of different times before finally, at some point, coming back out of there. Because if you keep in mind, if that's all air filled around that, it's going to be bouncing around a bunch of different times before it ever gets its way out, and then comes back. Now, you've got lots of ultrasound waves that are going into that little septa and are kind of bouncing around very randomly, each and every one of them. And every now and again, one's coming out. But it's coming out enough and steadily enough that you're going to get this constant kind of reflection back that goes on into infinity. And so that's going to sort of end up giving you that constant kind of picture of the amplitude coming back to you, because it's sort of generating its own return signal all the time, because you're constantly getting signal coming back to it. Super hard for me to probably put those into exact terminologies, because like I said, the physics of this can be quite complicated to read, and at the end of the day, probably not too important clinically. But in case anyone was wondering what a B-line is, there are some good papers out there that talk about this at considerable length and considerable like university level physics detail. All right, so as I was sort of saying before, what do B-lines remind me of? They kind of remind me of like a concert spotlight. So think about that as a way of getting novices to kind of understand, because I find quite quickly within the first week or two, people ask you the question like, so are those B-lines, are those A-lines? So forget about sometimes the terminology. I would sort of give them something more contextual to kind of make it a bit more practical. And so why do we care? Well, if you see lots of B-lines, so more than 3 B-lines in greater than 2 lung regions bilaterally, Lichtenstein has kind of coined that the lung interstitial syndrome. And this can kind of be representative of a bunch of different conditions, probably some of which are more common to us than others. In particular, pulmonary edema. So thinking CHF for our kids, as well as ARDS and other conditions that are going to cause sort of global edema of the lungs. Thinking about interstitial pneumonia and pneumonitis, so chemical pneumonitis or aspiration pneumonitis, and then thinking about diffuse parenchymal lung diseases, so kids who may have, sort of congenital issues or other kind of infectious processes. If they're focal, however, then you're thinking about these sort of conditions, right? So a pneumonia can literally just be a few B-lines if it's not quite reached the quite reach the pleural surface. Atelectasis can appear like B-lines if it's drawn some fluid into there. Contusions and sort of traumatic events that are causing a single lobe of the lung to be involved can certainly cause that. And then less commonly things like infarction or like localized pleural disease and sort of neoplastic processes. So quick take-home points. B-lines represent an instructive artifact and are not typically seen in healthy lungs. They're non-specific and they have to be interpreted within the context again, like I've said numerous times in this talk. And then those focal versus generalized patterns are going to suggest different clinical entities. So looking all around the lungs is going to be helpful, not just seeing that there is some B-lines in one particular place. Final take-home message for the whole talk. Cardiac IVC and chest ultrasound during resuscitation individually all have their limitations, as we've sort of got to, but in a sort of holistic picture can give you a lot of information about what's going on with a patient. Think about them in the context of each other and more importantly as related to that patient, right? So what are you actually seeing and what are your findings? You can see all these fun findings, but if your patient looks completely well, they're probably things that you don't necessarily need to get too alarmed by, but if they look very unwell, these things may direct you to do some immediate resuscitative efforts. Okay, all that said, let me see if I can, is there any like burning questions people have from outside or you guys here? I can see if I can hear you guys now.
The definition, you said like you need to see it in, or the diffuse B-line, like in both lungs, that's the definition?
Yeah, so greater than 3 within 2 lung areas bilaterally. Anybody from Hangouts got a question? Sorry, I breezed through a lot of the talk because we were getting a bit behind.
Can you hear me?
Hello?
Hey, in a child with congestive heart failure that you fluid overload accidentally, how quickly will you see those B-lines appear?
You say disappear?
Up here, if you start fluid overloading there.
Yeah, relatively quickly, we think. Our sort of typical way of determining whether someone's gotten too much fluid is really listening for crackles. And we do know that we often will see the B-lines well before the crackles are going to sort of appear. So I don't know if I have a specific answer about from the time you put IV fluid in to when those crackles are evident, but we have had numerous cases where, whether someone's in congestive heart failure or they're just having, SIRS, where, a lot of fluid's been given and well before someone is sort of, determining, oh, I think I hear crackles in the bases. If you look at the lungs, seeing B-lines already start to develop. The question of where that falls into your sort of sepsis guideline pathways and whether it's as valid as, listening for crackles and whether, you should continue to give fluids is a bit more complicated, but I would say that, yeah, it does happen relatively quickly.
And Lichtenstein will say that it's basically instantaneous, that the moment you have leak into your lungs, the leak shows up as B-lines. So that idea, we're used to interpreting X-rays and thinking about radiological lag for things like pneumonia, and for appearance of B-lines, apparently very rapid. We've had some experience on the disappearance of B-lines that also suggests that can occur rapidly. We had a newborn come in, I think a year and a half ago, who ended up being diagnosed with TTN, partly because their lung ultrasound showed diffuse B-lines with a normal functioning heart and without the kind of confluent ground glass appearance that people use to describe RDS. And the kid was put on positive pressure ventilation and rechecked like 10 minutes later. And along with their SAT and their appearance having improved, the B-lines had almost completely resolved also. So I think there's an argument that you can make for it being a very rapid occurrence.